thought that a good topic to talk about, especially with the night nurses, would be the new in-house attending coverage and kind of what it means for the nurses, what it means for the medical team, what the expectations are, maybe some of the reasons why we did this, and what we're hoping to observe, during the time that we've done it to kind of gauge its effectiveness. So, I can say a lot about all that, but I thought I'd start by just seeing what people's impressions have been so far over the first 16 days that we've done this, and what you think of it, and what questions you have. Hi, Manny. Does anybody have?
Do you mean, were you talking, I'm sorry, I missed the first
part.
part.
I said we're going to talk about, having attendings in-house, and kind of the reasons why we're doing it, what we're hoping to accomplish, and what some of our concerns are, and find out what your concerns are and questions.
I mean, I love it, but I think it's made the transition into July a lot easier than it has been in the past years, but I don't know. I think even if you're not really here a lot, it's nice to just have that, and I think it is kind of nice if you're not here because it helps them kind of try it on their own first, but just having that there. I think it gives the nurses a sense of security. There's someone that you do know that you can go to if it gets a little crazy. So, and we definitely have had moments where we have a kid arresting, up here, and then a kid crashing on the ECMO down the hall, and that's those moments. An attending shows up anyway, but it's a little bit even more secure to actually have you here. But,
all right, thanks.
Yes.
Any other comments or questions? Has anybody worked in other units where there was an attending physician present 24/7?
Never. I didn't. But it was just a regular floor.
But there's still an
floor,
attending.
yeah, we just had attendance.
Okay. And was that? Do you think that was a good or a bad thing?
It was nice. I never, was afraid to call them. Just felt more comfortable.
All right. Any questions about it, or wondering what your role should be, or what the attending's role should be? Is there any kind of ambiguity about who's the kind of primary person to contact, or in what situations you want to utilize the fact that there's an attending in-house? Any of that?
Why don't you tell us from your perspective, Michael, how you would like to see us use you?
Okay, well, part of that I think is dependent on or understanding it is understanding the philosophy of putting attendings in-house. Okay, so there's a couple of different ways to look at this. The first is that this is pretty much the standard at the large pediatric cardiovascular programs, is that in their dedicated cardiac ICUs there is an attending physician 24/7. And at some institutions that has been both functional, their attendings were there all the time anyway, so they thought it was just simpler to put them in-house. In some cases, anecdotally, that's been because there have been sentinel events where the institutions have decided that there were preventable adverse events or deaths that could have been, the outcome would have been different had there been an attending in-house. And so they've made the decision to do that. And then the other kind of philosophical foundation for doing it is that attending physicians can optimize the throughput of the unit, that they, things will happen overnight that wouldn't happen if they weren't there. So it was very rare for us to be extubating patients in the early morning before, and to be available for procedures in the middle of the night. And so the thought is that by having an attending physician present, not only do you just have a second set of hands for the situation that Allison mentioned where you've got two bad things going on at once, so you can't be two places at once. You can also do some things that you wouldn't do otherwise, not because the fellow or the other trainee can't do it, but because if something went wrong doing it, you wouldn't like it that an attending wasn't present at the time. If a patient gets extubated and can't be re-intubated and there wasn't an attending physician at the time, that is just, it's generally harder to defend that practice. And so now, we have that person there and we can do that. So those are some of the reasons why attendings have been put in-house in other institutions. And some combination of all of those is why we've gone to it here. Now, I would say there hasn't been a Sentinel event that really drove this, but there have been a couple of events, I would say in the last 3 years, and you can stop the tape at this time if you want, but there have been a couple of events in the last.
Would you like me to?
No, it's okay.
Okay.
Where, I mean, I personally believe that if there had been a tenant in-house, that things might have gone differently. And, unique events like that aren't necessarily why you change policy, but it's those types of events, I think, that make people think this is a good thing to do. Now, the truth is, if you look at the literature on this, and I have, there isn't a ton of great data to support the concept of in-house attending, particularly in the adult critical care world. There's minimal data to say that this improves outcomes. There was just a large paper published in the New England Journal where they looked at ICUs across Pennsylvania, and having attendees in-house or not really didn't impact mortality at all in this large kind of cohort of 70,000 or more critical care patients. There are many single center studies out there where they kind of look before and after the institution of a 24/7 policy, and some have shown some benefits on clinical outcomes. More commonly, if they've shown a positive result, they've shown it on resource utilization. So for instance, in this month's issue of Critical Care Medicine, CHOP just published their before and after results from in their PICU, and they show that they reduced length of stay and length of mechanical ventilation considerably from the before to the after era. And so those aren't insignificant findings. I mean, that's major resource utilization. If you get kids out on average half a day earlier, you're saving a lot of money by doing that. And that's largely tied to getting them off mechanical ventilation. So, I mean, these aren't perfect studies. They don't tell the whole story. It's never been done in a dedicated cardiac unit like this, or dedicated pediatric cardiac unit like this. So we don't know the answer here, but at least it's to say that there's mixed data out there, but there are some that suggest that this might be beneficial. So it's our job, really, over the course of this time, to study the effects and say, is it beneficial? And again, my guess is that you're not going to be able to move the needle on mortality very much. I don't think that's where having attendings in-house is going to make a huge difference, but it is probably going to be in this throughput and resource utilization and getting things done faster than they would otherwise. So that kind of leads into what are the expectations, and I would say, the expectations for us, loosely defined, are to maximize this throughput, to be available to do procedures and other kind of therapies in the middle of the night that we wouldn't have been available for. So the one that I'm, particularly focused on is getting kids extubated. And so, this is something that's going to take a little bit of a culture change for people who've been night nurses for a while. There's a lot of kids that we wouldn't extubate at 3, 4 in the morning, but now the expectation is that we do. Because it doesn't seem like a big deal, but, if you extubate a kid at 3 instead of at 10, there's a chance that you could send them out of the unit a half a day earlier, potentially. And, like I said, these half-day units are very important when you look at total resource utilization over an entire fiscal year. So that's a big one. I think we'll be more likely to do chest tubes in the middle of the night if we're here, and that was a procedure that I would typically not have a fellow do because, it usually goes well, but when it doesn't, it really doesn't. And so, now if I'm here, I'm just going to have them do it. And again, that may cut 6 to 8 hours off their ICU stay, and that we think that's important. But the biggest concern on our part has been what it's going to mean for the fellows, and any kind of ambiguity that it does create for you in terms of who should be contacted. We still very much want the fellows to be the first person contacted about things. There are going to be some times, like last night, where we're in different places, and Brandon was doing one thing, and I was doing another, and someone came up and asked, should we just extubate this person? And I said, well, yes, and so, there's a situation where I've taken away a decision that Brandon could have made, and is the accumulation of all those decisions over the course of your year and over the course of your training that help you kind of form your clinical practice. And so are we going to take away from that a little bit? Yeah, by necessity, we probably are. Does it help the patients to do it? I mean, I think that's what we're going to try to figure out. And so, but we still want you very much to go to the fellows first and realize that this is an important part of their training. and it's gonna be on us to figure out how to train them in, you know, in this environment. And, you know, bedside teaching is, you know, I mean, it's really a science, and, you know, some of us haven't, you know, really been polishing our skills on that recently. So, you know, it's a challenge to be at the bedside and know exactly what you wanna do, especially in a situation where it's becoming critical, and allow someone to go through that decision-making process. And we all have to be kind of patient with one another as we're kind of recalibrating and figuring that out. But, you know, we want to try to preserve the fellows' experience as much as possible. It's been a great part of this fellowship program for a long time. And so this, you know, kind of balance, this tension between doing what you think is right for the patient by having a more senior person involved versus allowing a more junior person to go through that educational process. It's not an easy one to mediate, I'd say, from my perspective. So, so I think those are kind of some of the reasons why we're doing it. I think what some of the expectations are, what I think some of the challenges are going to be, and so I can stop there and then see if there are any comments or questions related to that.
So Michael, what would be the expectation if the fellow would direct that the child is to be extubated? Does that necessarily mean that you have to be awake? It just means that he can go ahead and do it, but if we run into trouble, then we can get a hold of you, right?
Yeah.
Or if a chest tube needs to be put in, he may go ahead and do that without the attending at the bedside, or would the attending be up for those?
I think yes and no. I would say that we should be notified that these things are going to happen, just like we would have been if we weren't in-house. I mean, fellows were supposed to tell us if they were going to put in a chest tube or do really any kind of major procedure, intubation, extubation, chest tube, or line. Those were decisions that when we were at home, we expected the fellow to tell us that they were doing it. We didn't feel like we needed to come in necessarily to do it, but we had to approve of whether that would be done with us not in-house, or, you know, and approve of the decision-making to do it, because those aren't trivial decisions for different reasons. So I would say that expectation is the same now. It's not that because we're here they can just do it if they want to. They would still have to go through that process of saying, is this the right thing to do now? You know, if I'm putting in a line, am I putting it in the right site? You know, if I'm extubating it, is appropriate to extubate now? And we still want them to go through that process with us. But, you know, so that, I guess that doesn't really change. The only difference is we might be more willing to do it now, or I would be more willing to do certain procedures now because I am in-house rather than
So that would necessitate them calling you. That wouldn't be the nurse's responsibility. There would be communication between you two on what the plans were.
No,
and what was gonna
they would have
happen.
the primary communication, but what we would ask of all of you is that if they want to do something like that you said, have you checked this out with the attending yet? I mean, because I would still say that, you know, we want them to go through the process again of making the decision that they would do this, but these are important enough decisions that, you know, someone who's had more experience should make the decision of whether that's the right thing to do at that time.
Yeah. I guess I don't know what you guys think, but I guess, you know, sometimes when the kids start to swirl or start to go down the tube, now that you're in the house, I know in the past at some point we'll say, have you talked to the attending? We would just be that same process, that we would just say, is it time to call Michael? Is it time to do?
Yeah, and like always, so yes, and like always, and I mean, I used to say this many times, you know, you don't have to wait for the fellow to call the attending or to say it's time to call the attending. I mean, whenever a bedside nurse feels uncomfortable about where things are going and they feel like they need that attending physician at the bedside, that was true when we were at home, that, you know, you could call us and say, we need you to come in now. And I mean, I would say it happened rarely, maybe, you know, 2 or 3 times a year for any one person, maybe, that a charge nurse would call them and say, I think you need to come in, you know, independent of the fellow calling them. But it's the same process. If you're uncomfortable and you're not getting the response that you want, you know, you call us. And now it's a lot easier because we're 30 seconds away. So, you know, I think that is exactly the same.
Okay.
Exactly the same.
So how are you structuring the handoff time? Like when you're going to say goodnight and retire to the room, are you doing rounds late at night? I know you do them around 5-ish. Are you doing them again later?
Yeah, I mean, we've set the general expectation that somewhere between kind of 11 and midnight or around there, that there would be midnight rounds where you go through each one of the patients. And the 2 times that I've been on so far, the 3 times that I've been on so far, we've coordinated that with the huddling process.
Okay.
I would say that we might want to consider separating those because, like, again, one of the advantages of having us in-house is that we can really do some teaching, more teaching with them, like right around the patient care that's happening at the time. So, like, I would find it particularly helpful for me to go with a fellow bedside to bedside and say what's going on and do more teaching at that time. But I don't think that the charge nurse really wants to sit there and listen to me do that. They're more than welcome to. But Tiffany was telling me how many times she enjoyed the fast huddles last night.
They lasted an hour and 40 minutes
Right.
one day, and I thought Kayla was.
So I think that, you know, so we have to, I think we have to decide whether that's going to be a huddling process or not, because, you know, the flip side of the potential negative impact on fellows' education of us being in-house is that we could have a positive benefit because we're there to do more teaching. It's a lot easier to talk to someone about what you want to do at night when no one else is around than it is either during morning rounds or when they ask you and say, well, is there anything I could have done differently? I mean, that's very hard to teach somebody what you would have done when you weren't even there to observe the physiology and observe the exact clinical situation. So I would say that we would want to do a evening rounds between the fellow and the attending. That's what I would want to do, and I'm not sure that should be a huddling session too, because, you know, I don't want to rope the charge nurse into an hour-long, you know, session. So
Is it valuable, I'm sorry, Melissa, go ahead.
And the respiratory therapists too, because they usually huddle too when they go.
right. So I think the huddling should be separate, you know, personally, and that, you know, at some point, attending the fellow have to go through the unit and say, what's going on, you know, what's our plan for the rest of the night now, and, you know, what parameters to call me and stuff like that.
Do you still see your teaching as being bedside, though, between you and the fellow? So that the nurse could, if she's available, also listen, partake, and learn
Yeah,
in
absolutely.
that process?
Always encouraged.
Okay,
Encouraged.
so that's an open invitation to listen and ask questions.
And it's nice to hear that kind of stuff on nights too,
Absolutely.
because you get a lot of it on days.
Yes.
And on nights, people will say, well, I don't hear, you know,
Right.
what happened in rounds, or I don't get to hear the whole
Right.
spiel.
So, I mean, different folks, I guess, will have different policies on this, and some may not spend as much time really going in detail over the patient's, you know, care and their physiology and whatnot. And then it may be appropriate to combine them and do a huddling or whatnot. But the way that we can give a little back to the fellows, because we are, almost by necessity, taking a little bit away by being in-house, is to do this more extensive teaching at night. And so I think that, you know, I think that we should be doing that, and I think that, you know, we don't want to, like I said, rope somebody else into that if they don't want to be part of it.
But you know, as we have this influx of new nurses and new grads, it certainly would be a good way to develop everybody's knowledge if the nurses were included. And the expectation sort of is, if you're not busy, to listen.
What other questions or comments?
I heard a rumor that we're trying to phase into having an NP here at night as well as a fellow. Is that true? Or-
Yeah, that is, there's been some movement in the MP staff right now, which leaves them, I think, more short-staffed than they were before. And so I think it'll be a little bit of time before there is an NP at night, but I think that's very much also in anticipation of expanding the bed capacity, that it really would be better to have, you know, 2 frontline people, so to speak, at the attending. So yeah, I think an NP and a fellow would be the ideal. But I mean, and everything that I said about, you know, attending fellow relationship would be the same for the NP. I don't really, at this point, don't view them as having different, like fellows and NPs as having very different roles at night. So. Any other questions or comments? I mean, I think this is something, I just said that and then I just started talking. I do want to hear if there are other questions or comments, but I just made me think of one other thing I want to say, which is that, you know, this is a really evolving process. I mean, obviously we only be doing it for 2 weeks, and it's a major change for a unit. And so, you know, we would really appreciate feedback and, you know, hear what's working, hear what's not, hear where there's confusion and everything, because, you know, we're all trying to figure it out, and it would be a complete and utter lie to say that we had it figured out before we started. And so we really do want to hear back from the nurses, because night nurses are greatly affected by this, and the whole flavor of the unit changes a little bit with the attending in-house, and so it's really important to get comments and feedback back so we can address things, kind of, if there are problems, address them, and if there are things we can do better, to do that. So
How would you like that feedback? What do you think?
I don't know, it's a good question.
Through Jenny,
I mean,
Sue?
there are some committees that are forming within the PCT that are gonna be both nurse and physician led. Probably the operations committee is a good one to send that through. I mean, before that process is well established, I think, through the nursing leadership and in the unit, giving comments and asking them to pass it along. And I mean, certainly Rob, and to some degree John, should be notified of these, issues and concerns. And, so I don't know, right now writing it down on a sticky note probably is the best, or sending an email and having that forwarded, and then we can kind of deal with those questions and comments, as a group.
Okay.
So.
I know I had spoken to you at one point about whether there'd be possibility of adding some additional education specifically on the defects, if we could do an evening kind of presentation on that, because then we could hit the 3 to 11 staff, hit the night staff, and then maybe the day staff can watch it on the
Yeah, I mean,
when we videotape it.
I think that's perfectly reasonable. I mean, especially, it seems like there's been a lot of busy nights in the first couple of weeks of doing it, which I guess is one way to make sure that everybody likes it, because everybody feels like it's easier than it would have been if we weren't here. But but there are going to be nights that aren't quite that busy, and I think it's very reasonable at that time to do some teaching,
Okay.
Similar to either the way we do on morning rounds, or or the kind of cardiology model.
Do something in the evening. Maybe we can set that up more towards the fall when to get the fellows settled.
Yeah.
Okay.
And things are, and that's another thing. Things are going to look a lot different now than they do in a few months. I mean, the fellows will adjust. They'll become more independent. They'll have the ability to deal with just some of the basic stuff that they don't deal with, as easily right now. And so you might see the attendings in the unit a lot less than you have the first couple of weeks. So we're just going to kind of have to see how it evolves over the course of the year.
Okay.
And maybe we see these kind of basic needs for the attending to be present, either based on acuity or based on the time of year. All right.
All right.
Anything else?
Well, thank you, Michael.
Pleasure.
Thank you.